This is going to go to my YouTube channel, but it's going to be private right at the moment. So
Okay.
nobody will see it until I turn it on for the class on Wednesday.
Perfect.
So it's kind of being live, but no one's going to know.
I mean, yeah, right. Nobody's watching.
Just how we record it right
That's
now.
okay.
Because we'll be able to be easier to use it later if we record it right now on YouTube. So
Sure.
right, you're good to go. I got that screen on, and your sound, and my sound at the moment because I'm still yapping.
Okay.
All yours.
Hello. I'm Matt Rodgers. I'm one of the fourth-year residents at Freeman, the emergency department. I'm here to talk to you a little bit for your refresher. A little backstory on me. I was a paramedic before medical school, so I am very familiar with having to do refreshers every couple of years. But I thank you for spending your time with me to talk a little bit about some spinal trauma, something we're all familiar with, and a little bit of traumatic brain injuries, just a little refresher on different presentations that you can get with car accidents, falls, things like that we go on every single day. So that is an actual picture of Freeman's emergency trauma bay. So the first thing we'll talk about is some spinal cord injuries. Very common thing to happen for different people, especially the older we get, the less protection that we're going to have. So everybody recognizes this picture. Somebody's out there complaining of back pain, neck pain, and you come up there and it's a little fender bender, and they're sitting out there on their phone. These aren't the types of accidents that are going to cause spinal cord injuries in a healthy adult, as you guys are all aware, but they will be complaining of different types of neck pain and back pain, and it's the worst day of their life. You just have to remember that you see this every single day, and they are having probably the worst day they've had in a very long time, even if it's really nothing for you. Here's another example, parking lot leaving Walmart, and they're complaining of big back pain. But then it does get actually severe, as you guys have seen in the past. Things like this, when you walk up on scene, the mechanism of injury is there. Has to open up your mindset of what could possibly be going on with the patient. Compared to this, nothing probably is going on with them, but this, if they're still alive, a lot of different things could possibly be going on. We won't get into all of the advanced trauma life support that you guys are familiar with, but we will focus more on what you're going to find with like the neuro exam on somebody who has a spinal cord injury, and then if they have a brain bleed or traumatic brain injury of some sort. And one other picture that you guys are all familiar with seeing. So a little bit about spinal cord injuries. Majority are due to motor vehicle collisions due to the high rate of speed and a lot of impact that they can have if they're having rollovers. A lot of axial loading can occur, which makes them the most common source. Followed by falls. Everybody has the 2 o'clock in the morning fall. You know, grandma went up to go to the bathroom and fell down and ended up having a fracture, and some of that bone, you know, became retropulsed into the spinal canal, and she has a spinal cord injury. Violence and then sports injury surprisingly follow, but motor vehicle collision and falls are going to take up over 90% of what you're gonna come across with having to have a really good neuro exam. Males comprise 81%. I don't know why that is. I don't know if we really do things that women don't do, but they have 81% of people who have spinal cord injuries are going to be male. And the average age, surprisingly, is actually 43. I would assume it would be younger due to the things that we actually would do and how brave people are at a younger age, but it is actually 43. Incidence is about 40 per million population, so it's really not super uncommon. I mean, it's not going to be something you're going to see every single day, but you will have to know kind of what to expect or what to look for, because it does occur. And the lifetime cost per the patient actually exceeds $4.5 million if they do have a spinal cord injury, so it's very, very expensive. Usually they end up on Medicaid or Medicare, so the cost is covered by the government, because not very many people can afford the $4.5 million to take care of themselves, to include home health and wheelchairs and doctor's visits and medicine to help with the pain, because neurovascular pain is extremely painful and there's really nothing good to treat. So they have a lot of visits because of neuropathic type pain. So when you're talking about spinal cord injuries, the most mobile segments of the spinal column are going to be C4 through C6 in L1 through L2. This is due to it being further down in the cervical spine, and then the thoracic is usually protected by the rib cage. So the adjacent segments of the spinal cord at higher risks for injury. So a lot of times you're going to see a low cervical or high lumbar type picture when you're looking at a neurovascular exam. And like I said, the thoracic column has more protection from the ribs. But when there is thoracic bony displacement that retropulses into the spinal canal, the injury is usually pretty devastating. They probably won't ever walk again, or it's so much force that they're going to be deceased when you get to them on scene. So what is the presentation like? The first ones that we saw, the first pictures, kneeling down on the ground talking on his cell phone, is not what you're going to see. They're going to have a lot of pain, tenderness at the level of the injury. They're going to be complaining of weakness in an extremity where they can't move their legs, they can't move their arms, or they can't move both, obviously. They're going to have some numbness and paresthesias distal to the level of the injuries. And you're going to have paresthesias at the time of the injuries. That's usually the sign of like the cord or the roots that have been compressed. But if they have no paresthesias or numbness, but you get to the hospital and they're like, wow, like my arms are now tingling or my legs are tingling, this could be a sign of instability of the spinal column because there's a fracture that hasn't actually compressed anything. But over time, swelling occurs, and now it's starting to cause the paresthesias and the numbness. So Cauda equine syndrome is one of the things that we have to rule out in the emergency department all the time with people who come in for back pain. What that is it's a compression of the Cauda equine, which I'll have a picture of it. What the Cauda equine is at the very end of the spinal cord is a whole bunch of fibers that come off. You have what's called the filum terminale, which is the very tip of the spinal cord. It tethers to the sacral area of the spinal column, and before that you have a whole bunch of little fibers that come off, and this is actually the Cauda equine. And so that's why we can do a lumbar puncture, is because these little projections of the spinal cord, or these little fibers, are actually just kind of floating there, bathing in the CSF. And so it's when you stick a needle in there to do a lumbar puncture, it would be like trying to hit boiling spaghetti in water. You're just not going to hit anything, or you're not going to damage anything. But what they're going to be complaining of is going to be a low back injury. They're going to have urinary retention. That's the number one sign that you're going to have. They're going to say, man, I feel like I have to go to the bathroom, but I can't go to the bathroom. So what we do is we try to get them to urinate. They get as much out of their bladder as they can, and then we will bladder scan them. And anything over 100 mils left in the urine is positive for urinary retention. They're also going to be complaining of perineal paresthesia. And how I ask that is, can you feel yourself when you wipe after you go to the bathroom? If they say, nope, it's completely numb, then that's consistent with perineal paresthesias. And then loss of bowel. Have you had a bowel movement on yourself and didn't even know it because they're having the numbness and tingling and they have no control over their bowel movements? One thing to be cognizant of is that urinary retention can actually present as overflow stress incontinence, where they are saying, oh no, I'm going to the bathroom just fine. But really what's happening is you scan their bladder and they have over a liter of urine in their bladder and they're still urinating, but that's just because the detrusor muscle can't hold in the urine anymore, and so they're actually having overflow stress incontinence but not actually urinating. And this is actually a surgical emergency. If you suspect anybody of this, then you have to get on board with neurosurgery, and they have to go in there and do a decompression, or they'll actually lose their ability to walk ever again. And I actually had somebody who had all the signs up in Nevada just about a month ago. I don't know if she ended up having it. I had to send her up for an MRI up to Kansas City because we don't have that capability in Nevada, Missouri. But she had all the symptoms, saying, I can't go to the bathroom, I can't feel when I wipe, and I've had a bowel movement on myself today. Is she pain-seeking, or is she legitimate? I don't know. But it's Cauda equine syndrome until proven otherwise. So here's what I was kind of talking about. The dark yellow at the top in between the spinal cord and the Cauda equina is the spinal cord, and then you can see the little fibers coming out, and they have all the roots that are going in between the vertebral bodies. And one of these end up getting pinched, and it provides all of the sensation and nerve activity going into the lower extremities and the perineal region, and also to the bladder. So, talking about injuries as to what you're going to expect, you have to be kind of familiar with this. Obviously, you don't have to remember all of them. This is the dermatomal pattern, where you can say, okay, they're not moving their arms. Well, if they're not moving their arms, you've got to figure it's going to be a high cervical or low cervical injury, but above the thoracic area, because the nerve fibers exit obviously up there. And so if you have a low thoracic injury, the nerve fibers above it should still be intact, so they should still be able to move their arms. But if they're not moving their arms, they shouldn't be moving their legs either, because everything distal to any type of injury should be affected as well. So the big ones that I always remember is T4 is right at the nipple line, and T10 is at the umbilicus, or umbilicus, however you want to say it. And that gives you a pretty good reference range. You know, kind of in the middle, you can guesstimate, okay, T6, T7. You don't have to be exact. T7 is going to be at the angle of the scapula. T4 is going to be at the flat part of the top part of the scapula if you're looking at the back, and then umbilicus is going to be straight through the back, where they're complaining of their pain. And then the arm movements, you know, C7 is going to control the triceps, and C6 is the biceps. C7 is going to be your 2 index fingers, and C8 is going to be your little finger and your ring finger. Just things to remember. It's like, okay, these could be the part of the cord that's affected because they're not moving it. So a good neuro exam's going to be having them move their arms, making an okay sign, spread their fingers apart, put their fingers together. Don't let you push their fingers together, and then have them open their fingers against your resistance to see if they actually have the strength there. Same thing with like dorsiflexion and plantar flexion. It checks a little bit of the lower lumbar segments. Just something to kind of be familiar with when you're doing a neuro exam, saying, okay, it's got to be a cervical, or it's got to be in the thoracic or the lumbar area, because this is the level of the paresthesia or the numbness or the inability to move. So what is spinal neurogenic shock? It's due to a cervical or a high thoracic cord injury above T6. It's relative hypotension due to the loss of sympathetic tone below the level of the lesion. So the thoracic part of your spinal cord is where all your sympathetic tone comes from, and that's why it's due to a higher cervical or very high thoracic cord injury, because the parasympathetic is from your cervical and your lumbar area, and your sympathetics from your thoracic. So it leaves unopposed parasympathetic nervous system activity whenever you knock out the sympathetic tone, anything below it. They'll have warm, dry skin, norm cap refill, because they still have blood flow going to it. It's all neurovascular. And you'll have paradoxical bradycardia. And this is, again, coming from the loss of the sympathetic tone. So you're having parasympathetic and sympathetic stimulus going to your heart. Well, if you've lost the sympathetic part of your heart, which would cause you to have a fast heart rate, you're just going to have parasympathetic tone that's unopposed, causing the bradycardia. And this should be differentiated from hemorrhagic shock. So anybody who sees a serious accident, you have somebody who has low blood pressure, you have to initially assume that it's going to be some type of hemorrhagic shock. So you have to find where they're bleeding from. Do they have a arterial bleed? Are they bleeding internally? And it's spinal neurogenic shock if you have controlled all the bleeding, you've done good fluid resuscitation, you don't see any signs of bleeding, but it's hemorrhagic shock until proven otherwise, because that will kill them just as fast. So hemorrhagic shock, like I said, is treated with fluids and bleeding control. Spinal neurogenic shock should be suspected if the symptoms are present, but only after bleeding has been controlled with adequate fluid resuscitation. And that's just 2 large bore IVs, just pumping the fluid in them to see what happens to their blood pressure. But you also want to be careful to avoid too much fluid. Obviously, in Joplin, everybody knows that we are not the epitome of health. They have a lot of cardiac problems, congestive heart failure, MIs, things like that. So you can easily cause somebody to have pulmonary edema or worsening spinal cord edema, which would cause even worsening of their symptoms. So after you've given a couple liters, you should see some type of improvement, whether it be a decrease in their pulse rate or an increase in their blood pressure. And if you see a little bit of movement and you don't have any signs of bleeding, then you can say, okay, well, maybe spinal neurogenic shock is the cause. Levophed is going to be the pressor of choice that you're going to put them on. Unfortunately, there's no controlled studies, and I looked for any type of controlled study that would give you an indication for the optimal blood pressure to avoid cord ischemia. What do you want to keep it at? There's really no good studies. Obviously, it's probably a pretty tough thing to have a study, and we can't obviously go in there and cause somebody to have neurogenic shock just to see. That's unethical. But our goal is just to maintain a blood pressure sufficient to sustain intact mentation and urinary output. Our goal for urinary output is going to be 1 ml per kilogram of the patient's weight per hour, is what we consider good urinary output. In a trauma situation, burns a little bit different. In a normal human being, we like at least 0.5, but in a trauma patient, we want 1 ml per kilogram per hour. Just some tidbit of information. So what are some C-spine fractures? Well, you have chip fractures, you have clay shovelers, which is the spinous process gets pulled off because somebody's sticking their shovel into the ground and pops off their spinous process. That's considered a stable. We just discharge them. Same thing with a transverse process fracture. But what we have is this little acronym, Jefferson bit off a hangman's thumb, which they're all different unstable C-spine fractures that we have to look at. So Jefferson is a C1 burst fracture. So you can see at the very top, right below that arrow, that little round circle is going to be the dens protruding. That's part of C2 up into C1 ring. And where the arrows are pointing at is different fracture lines that you're seeing. And it's a ring fracture, so if you see one fracture, chances are there's going to be another one. This person just happens to have 3. So this is a Jefferson burst fracture. It's very unstable, has to go to neurosurgery or they'll be paralyzed. It'll cause a lot of edema, especially with it being that high. And this is a bilateral facet fracture, which is the bit. You can see that how the spinal canal or spinal column has shifted backwards. Well, you have little facets holding each other on the side, and so if one of them breaks, it shouldn't move because you still have another one to back it up. But when both of them fracture, you'll have retropulsion of the spinal column back into where the spinal cord is, and you can just imagine on MRI what that would look like. It's putting a whole bunch of pressure on that spinal cord, and I bet you this person's paralyzed and probably will be for the rest of their life. And this is an odontoid fracture, so that's what we're talking about, the dens. It is the protrusion that goes and rests into the concave portion of C1. You can see that fracture line right there. So this is a type 3. There's 3 different types. Type 1 is stable. It's at the very tip of the dens. And type 2 is just a little bit further down, and this is type 3 because it's right at the base of it. So type 2 and type 3 are unstable fractures. Neurosurgery goes in there and puts a pin in there to keep it from moving and shearing the spinal cord. Obviously, it's right up there by the exiting portion of the foramen magnum, so you can imagine how devastating that would be. In the hangman's fracture, this is going to be a hyperextension type fracture, and it causes fractures at the interarticularis portion of the cervical spine. So if you see in the bottom left, the way that they actually really used to hang people was they put the knot at the front of the head, and not like the movies where they put it in the back. This was to cause that hyperextension, so you just snap that pars interarticularis part, and it ends up dissecting the vertebral arteries, and it dissects the cord, so they're paralyzed and they bleed out and then they suffocate. It's probably a pretty horrendous way to die, I would imagine. So teardrop fractures are actually pretty hard to see, but they're extremely important. Dr. Offit and I had one just a couple of weeks ago, and he ended up going to neurosurgery. So it's causing the prevertebral swelling associated with the anterior longitudinal ligament tear. So at the very front of the spinal column, you have an anterior longitudinal ligament, and it tears it off, and it pulls a piece of the bone with it because it's attached to the anterior portion of the spinal column. And it also has a posterior vertebral body subluxation into the spinal canal because it's pulled all of that forward. It takes a lot of force to get this to happen. But if you look over at the right, you can see the red arrow is pointing to an area that has a very small chip area that's chipped off. If you look at the column above and below it, you don't notice any type of irregularities with the cortex of the bone. It's all a nice straight line, and that's what we typically look for. It is one look like the other is something off. And this one obviously has the chip fracture, but if you also look at the spinous process, it's opened up in the back, because if you look above it, you have a certain distance, and then below it, you have a certain distance, but that one just seems really widened compared to the rest. So if it doesn't look the same, then something's probably going on. You better start looking a little further into it. So you can't read my picture, unfortunately. It says, and remember, you should always stop CPR when the second ouch from the patient. I always thought that was funny. If they're moving around, you don't need CPR. Everybody's probably seen that done a time or two. So different syndromes that you can have with spinal cord injuries. Central cord is it's actually my favorite. It's hyperextension injury. The symptoms are you can dance, but you can't play the piano. So you'll actually have upper motor weakness is more pronounced than the lower extremity weakness. So you're able to dance, but you move your arms to play the piano. This actually has a very good prognosis. Most people have complete resolution after about a year. This is the MRI that shows the central part of the cord has been damaged. That's what on the left you can see the big white area of edema, and on the right is a T2 weighted. You can see infarction where it's not getting the fluid pulled into it. So the left one's T1 weighted, which is more fat, and then the right one is or bone. I'm sorry, and the right one is T2 weighted, which is water or fat. On the flip side of that is anterior cord syndrome. This results from a hyperflexion injury. I always think of this one as grandma's walking down the street, trips, hits her chin, and catches it on the ground or catches it on the table or something. It causes an anterior spinal artery compression, and you'll have motor paralysis and loss of pain and temperature below the lesion, but you'll have preserved vibration, light touch, and proprioception. So if you have complete motor paralysis and they can't feel anything except for barely touching them, or they can say, yeah, you're lifting my leg up, you have to consider that could be an injury to the anterior cord. And this is a very bad prognosis. Most people don't recover from this, and they have permanent loss of movement. On the MRI, you can see the front part of the cord has been damaged right up at the anterior portion of it. And I'm sorry, the picture on the right, it's terrible, but where the arrow is anterior, and you can see that area of hyperlucency, the white, where it's been damaged, it's not allowing fluid into it. So Brown's Sequard, this is one of the ones that we get tested on all the time. When I was a paramedic, they always said, oh, you can't ever have, if you have a spinal cord injury and you're only moving one leg but you can't move the right, then they're faking it, because any type of spinal cord injury is going to affect both sides, but that turns out to be incorrect. Brown's Sequard is caused from a penetrating hemicord injury. So typically in a car accident, you're not going to have something like this unless a piece of metal penetrates the neck or somebody stabs them in the back. You're going to have loss of the ipsilateral motor, proprioception, vibration, and light touch. So they cut the left side of the cord. You're going to have the same side where you can't move your left leg or left arm. You can't feel where it is in space, which is what proprioception is, and you're not going to have vibration or light touch, but you're going to have the opposite side because the way the fibers decussate or cross over in the spinal cord, contralateral loss of pain and temperature. So the right leg won't be able to feel anything pinching it or burning if it's in a fire. And here's a picture of that. Somebody obviously stabbed. You can see the tissue damage posterior and causes one side of the cord to be cut. So management of spinal cord injuries, ABCs, as you guys know, ABCs is the rule of thumb. If they don't have an airway, they're not breathing, you're not going to have a patient for very long anyway. So maintain the C-spine stabilization. Rigid collar that you guys put on is fantastic. We'll change them over to something a little bit more comfortable in the emergency department, like a Miami J. Spine board is used to ease log roll. I know there's a lot of controversy. Is the the spinal cord good? Is the spinal board bad? But right now it's still good. Use it to help at least move them, because you're not wanting to move their neck or their back at all. You can just use the board to lift them up. We have NEXUS Criteria that we do in the emergency department. I don't know if anybody's ever seen that. We'll go in there if they don't have any midline spine tenderness, if they're not intoxicated, if they have no paresthesias, if they have no altered level of consciousness, then we can clear their neck. Or if they have any distracting injuries, that will not allow you to clear their neck, because if they have a left femur fracture, that's going to be very painful, but they could still have a neck fracture. But if everything looks good and they're saying, nope, I feel great, then we can clear it without actually having to getting any management. And we started to implement that on the ambulance when I ended up leaving to go to medical school, so I never really utilized it there, but we utilize it in the emergency department all the time. And here you go. That's the NEXUS Criteria. No focal neurologic deficit. That is pretty common sense. If they say they can't feel their left arm, then there's probably something going on, or they're always have it, or they have some type of herniation or something. No midline cervical spine tenderness. They can have paraspinal tenderness, but no midline. And they're obviously able to talk to you. They're not drunk, because you can't clear a C-spine even with a negative CT scan, because they could still have ligamentous injury that would require an MRI if they're intoxicated, and they don't have the distracting injury. So that's most of kind of what you need to refresh on for the spinal cord. So the traumatic brain injury is also another important topic to cover. Little refresher, everybody loves this one. It's probably pretty hard to see on your screen, but you can see the different levels of the meninges. So you have the hair and the aponeurosis, also called the galea, and the skull, the soft tissue, and you have the duramater, which is hard mother, I believe, is what it stands for. And then you have the arachnoid space, and then the piamater, all that's part of the meninges, which comes into effect on where head bleeds occur from. So we have a little thing in the emergency department. When do we get a CT scan of their head? So this is just something you can expect to see. So if their Glasgow Coma scale is less than 15, even if they're like, it's right now it's May. Oh no, wait, it's November. Then it's still a confused but appropriate answer. Glasgow of 14. They're still going to get a CT scan after a head injury. Any anticoagulation, you guys are fantastic about asking this. They always, every time you guys have come in, they're like, nope, no anticoagulation, or they're on Xarelto or whatever. So good job with that. But that's obviously, doesn't matter what the mechanism is. If they fell down, they're going to get a head scan. Even if they say, nope, didn't hit my head, I don't care, I'm still going to scan you. If they're vomiting, that can be signs of a head injury. Age over 60, doesn't matter, you're going to get a head CT, because you're not going to get brain cancer if you're over 60 years old. If there's evidence of a skull fracture, which will show some evidence of skull fractures to refresh you for that. Any altered mental status, obviously, they're not making sense, they can't tell you the truth. They're all, my philosophy is every patient lies, so I have to do my job to make sure that I do what's best for the patient. Any alcohol intoxication, they're going to get a head CT if they fell, or if they got in a car accident or hurt themselves. So the first one is the epidural hematoma. The most common vessel is going to be the middle meningeal artery, which comes off of the carotid artery. This will present to you guys with loss of consciousness. Bam, got in a car accident, lost consciousness real quick, and then they come back and they're like, oh man, I hit my head, I think I just kind of blanked out, and they're back talking to you. And right now what's happening, if you have an epidural hematoma, is all that fluid is starting to accumulate in the head. Well, the skull, unless you're leaking out the blood, is going to be a closed system, because you have an artery inside the skull that's bleeding. It's going to increase the pressure, and it's going to cause what's called an uncal herniation or transtentorial herniation. You'll have a cranial 3 deficit, which will cause a dilated pupil on the ipsilateral side that's compressing that third cranial nerve, which we won't get into all the cranial nerves, but that causes pupil dilation. And they're going to have difficulty moving with the corticospinal tract. that's going to be affected coming off that same spot. Here's a picture of it. I always think it looks like an eyeball. It's a nice, sharp, delineated line that doesn't cross suture lines. Is how they'll say it on a test for us, or I don't know if they test you guys over that anymore or not. But they'll say it'll be a well demarcated line that does not cross suture lines, and sometimes they'll show you a picture. But that's what an epidural hematoma would look like, and we'll go into the subdural hematoma, and I'll show you a picture of that. These are by far more common. These usually are caused in the elderly or alcoholics that fall, and the reason why that is because they have so much brain atrophy that their brain shrinks, but the vessels don't shrink with it. So you'll have some gaping area where a bridging vein, which is the most common vessel that the subdural hematoma causes, will be pulled if they hit their head and their brain moves around, because now there's so much room in there that it will rip one of these bridging veins, and you'll have a large head bleed that does cross the suture, but it's not midline. And what that means is, if you look at this on the left side, you can see that big white area, how long it is. It looks irregular, it's not well demarcated, and it crosses that suture line at the top left. This one is a subarachnoid hemorrhage. You can see wide disperse areas of white. So these usually occur if you have like an aneurysm, a berry aneurysm in your head that just randomly ruptures. It's also more common in the elderly, but subarachnoids are pretty devastating. There's really not a lot to do for it. It's either you can go in there and coil it if you have interventional radiology, but typically they will present and they'll have to be transferred immediately to anywhere that has interventional radiology. They can go in there and coil it. Now, an interparenchymal bleed is looks kind of like a cancer, but it's just a random bleed in the parenchyma, or the big area of the tissue of the brain. So talking about what signs these are, this is raccoon eyes, which is a late sign of a temporal skull fracture. It's going to be bilateral, and they're going to say, yeah, this is completely abnormal. Where this is battle sign, which is going to be bruised at the mastoid process behind the ear. That's another good example of what would be a temporal skull fracture, which would raise your suspicion for a head bleed as well. And then this is really tough to see, but this is a hemotympanum. It's the most sensitive sign. Most people who have a temporal skull fracture will have hemotympanum. That's why whenever you guys bring a trauma in, we look immediately in their ear to see if we have any blood behind the ear. So there's the TM with the cone of light at the bottom, and you can see that surrounding red area. That's all blood that's holding or sitting back there behind the TM that needs to get out. So they most likely have a head bleed as well. So all of this stuff, what does it mean? It's going to raise intracranial pressure. So increased intracranial pressure is eventually going to happen if the bleed is significant enough, and that's what causes people to herniate. You'll have your normal ICP. It should be less than 15 millimeters of mercury, which we can test that. Yeah, I know you guys can't test that out there, but it's just a tidbit of information to know. And why is this important? It's because it affects the cerebral perfusion pressure. And that's what we're concerned about with it. Is there too much pressure fighting against the heart to get blood up to the brain? So the cerebral perfusion pressure is the mean arterial pressure minus the intracranial pressure. So obviously if the ICP is increased, CPP will be decreased, and the brain's not going to be getting perfused. So too much cerebral perfusion pressure can actually lead to cerebral edema and hypertensive encephalopathy. So there is a kind of a delicate balance. You don't want to increase your MAP too high. You don't want a pressure of 300, obviously, because this is not going to be beneficial to the patient. It's going to increase the bleeding, but it's going to also lead to the cerebral edema. So how do you notice if somebody has increased intracranial pressure? Well, everybody remembers Cushing's triad. You'll have the widening pulse pressure, irregular respirations, and bradycardia. This all has to deal with the mean arterial pressure and the cardiac output. You're going to have an increase in the systolic blood pressure because you're trying to overcome the decreased cerebral perfusion pressure. So it's like, man, I'm not getting enough perfusion to my brain. The body knows this. It increases the systolic, and the diastolic is still there because it relaxes. Diastolic pressure is when the heart's not pumping. So you're going to notice a big wide pulse pressure of 180 over 63 or 180 over 32 or something. Irregular respirations, well, that occurs because the brainstem needs air or blood to get the oxygen to it. And so whenever you're having decreased perfusion, you're getting decreased oxygen to the brain. Now the brainstem's not getting it. It causes us irregular respirations. And then you end up with bradycardia for the sympathetic system is going to be overrun by the parasympathetic system because you're having decreased perfusion to the brain. They're also going to have altered mental status and vomiting. Those are going to be the most common things that you're going to see. They're not going to be talking to you coherently, if at all, and they're going to be thrown up all over the place, and you're not really going to be able to control it. So how we monitor it is an intracranial monitor. It's a monitoring system that neurosurgery puts in. I actually got to put one in the ER with a patient that had a head bleed. Very simple. It's a drill. You just drill it in and put a little tube in there and hook it up. And on the top left, you see their ICP is 10, so their pressure is good. You shouldn't be having any decreased cerebral perfusion pressure with a pressure of 10. So how do you treat this? Isotonic saline to avoid hyponatremia is going to be your go-to. You don't want them hyponatremic. If you're out on your own, you have a long transport time, and you know that their ICP is way elevated. They have all of the Cushing's triad. They have a head injury. They have battle signs or whatever it may be. You can try hypertonic flushes in 250 mil increments. What that causes is a shift in the sodium, which pulls out the fluid, which will decrease some of the edema. Obviously, the real quick, easy way is to elevate the head of the bed 30 degrees. This just uses gravity as your friend. Sedation, huge. The more agitated they are, the more aggravated they are, the higher the pressure is. So if anybody's ever been real angry or real agitated, you have all that pressure in your head. Your head just feels like it's going to explode because you're so angry. Same thing with increased ICP. If they're having an injury, they don't know what's going on, they're altered, they're going to have increased ICP just because of their agitation. So sedate them. Propofol is really good. Versed is going to be really good. Then we use things like mannitol, glucocorticoids, and even hypothermia. But the definitive treatment is going to be decompression or removal of the CSF, just to decrease that fluid that's actually in there. And decompression's done with a bolt by the neurosurgeon. So the herniation syndromes, we talked a little bit about this. The uncle herniation is going to be the most common epidural. You're going to have the ipsilateral pupil dilation because that third cranial nerve comes off of the uncle portion of the brain, which is in the third ventricle. You'll have the increased respirations, the Cheyne-Stokes type respirations. They're going to be having a coma. They're going to be posturing, most likely with extension, with the Glasgow of 2. And then they're going to go to apnea because they have increased pressure on that brainstem portion because now it's herniating through the foramen magnum. Central herniation is a little bit different. It's causing both sides. So uncle herniation is causing one side. That's why you have the ipsilateral or the same side. This one's going to have fixed mid-position pupils, but it's going to be bilaterally. They're going to have decreased level of consciousness. And if you have a cerebellar tonsillar infarct, the back portion of the brain, you're going to have pinpoint pupils and flaccid quadriplegia because the cranial nerves and everything exiting that controls the upper and lower extremities are going to be herniated and have pressure, and nerves do not like pressure on them. We used to do hyperventilation because it is extremely good at lowering the intracranial pressure. It used to be the standard of therapy because it works very quickly. However, now it's appearing to increase mortality because it reduces cerebral blood flow to the affected area. So you'll reduce the pressure in the head, but then you're also going to reduce the blood flow. So what good really does that do? It's only now recommended as a final effort if you're out and about and can't do anything and they're dying, it looks like they're herniating. you can just try to hyperventilate them as quick as you can. And hopefully get them to someplace that has a neurosurgeon to put a bolt in real quick before they expire. And that's it. Everything on the left. It says the only patient satisfaction question that matters is, did you die? That's exactly right. That's our job. You know, I mean, your job is to do everything you can, get them there alive. Once you drop them off, you did your job. Now it's our job. And then it's the surgeon's job. The one on the right actually is the Yankee Candle's new Candle Skilled Nursing Facility. It's their new scent. If anybody wants one, I know how to order it. We can do that. And here are my resources. Harvard Nuss Critical Care Medicine. We read that up to date, and Google Images for all my pictures. There's my email at the bottom, matthewtrogers123@gmail.com. If you have any questions, I'd be happy to answer. Just shoot me an email, and I'll get back to you as soon as I can. Thank you for your time. Good luck on the rest of your refresher.